Good morning, Mr. President. It's a pleasure for me, an honor to share with you. Can you hear me? It's a pleasure for me to share with you in the next 15 minutes our experience in cultivated stem cells for corneal failure due to limbal deficiency in congenital aniridia. As you know, the main reason of aniridia keratopathy is limbal stem deficiency. And the classical surgical approach is the limbal transplant, allogenic, both from a live or from a cadaveric donor. But the needs of donor and immunosuppression, the complexity of the technique and the limits of repetition are major disadvantages. In this scenario, cultivated limbal epithelial transplantation, known as CLET, gains relevance. A fragment of 1 or 2 limbal donor area, allogenic, both from a live or cadaveric donor, are seeded in an amniotic membrane in such a way that in 2 or 3 weeks the product is ready for implantation. And it is really easy to make the procedure. We made a clinical trial comparing allogenic versus autograft CLET transplant in patients with limbal insufficiency. And we found that at 2 years, the success rate was around the 80%, and at 3 years, the success was the 75%. But maybe the most important aspect was that there were no differences in the results between allogenic and autologous transplant. And we have to take in mind that aniridic patients can only receive allogenic transplants. But from this work, we reached much more knowledge. Regarding the tissue harvest, we found that in vivo confocal microscopy is the best technique to detect palisades of both, much more than slit lamp examination. And we found that the limbal niche structure of the donor did not reappear by 6 months after surgery. You can see in this slide that after 6 months of the harvest of the tissue, there were completely lack of palisades of both in the donor. Regarding isolation methods, we found very important that cell suspensions were much better than explant, as you can see in the right side of the slide. And we can optimize the technique. It's very important because one explant can be successfully cultivated up to 3 times, keeping the phenotype of stem cells, and can be used for both clinical or research purposes. Anyway, the needs of donor and immunosuppression, the cost of the procedure, and some cultures get contamination, those can be serious problem of the technique. In this scenario, mesenchymal cells, stem cells, gains relevance. Why? Because they can be autologous or allogenic, so there is no waiting list. Contamination will not be a problem of the culture. There is no need of immunosuppression. Mesenchymal stem cells come already extracted from their knees, so it is less traumatic for the cells, and it is less expensive, much more less expensive, so more accessible. Mesenchymal stem cells are a subset of stromal cells defined by their adherence that exhibit fibroblast morphology, express mesenchymal stem cell specific cluster or differentiation markers, and lack the expression of other cell markers. They can be obtained from adult sources, perinatal sources, or fetal sources. And they can differentiate to bone, cartilage, muscle, fat, neurons, and even to corneal epithelium. In this animal model of limbal insufficiency, the eyes that receive mesenchymal stem cells seated in amniotic membrane in the bottom of the slide express marker of epithelial cells, in this case cytokeratin 3, in yellow, or echidna. And more important, they can express marker of epithelial stem cells, such as cytokeratin 15 or P63. Mesenchymal stem cells has very peculiar properties. They are non-immunogenic. They have the capacity of differentiation toward other cell types. They create a regenerative microenvironment. They have antifibrotic and anti-apoptotic effects. They support tissue-specific progenitor cells. They have the capacity of immunomodulation, and they have the capacity of selective migration to the site of injury. This is incredible. Those properties has led its use being proposed for a lot of systemic disease, in such a way that right now in USA there are active 800 clinical trials with mesenchymal cells. Regarding the eye, they have been proposed for anterior segment or orbital disease, and for posterior pole, mainly in age-related macular degeneration and for some specific inflammatory problems of the posterior pole. And they can be administered for posterior pole through the vitreous, through the submacular, or through the subretinal area. Getting back to the cornea, which is our topic now, they have been proposed in the treatment of epithelial diseases, stromal diseases, and endothelial problems. And why are they useful in limbal insufficiency? Because they can secrete some trophic factors, they can inhibit other trophic factors, they can produce some immunomodulatory factors, and they can inhibit other immunomodulatory factors. With a lot of final results. They can induce cell proliferation, they have antioxidant, anti-inflammatory, antifibrotic, and anti-angiogenic effects. How are they used in the cornea? Using the exosomes or using the cells directly. Exosomes are products of the mesenchymal stem cells that work via paracrine effect in close contact with the recipient cells. We have experience using cells directly. How do the mesenchymal stem cells can reach the diseased cornea? By mobilization of endogenous mesenchymal stem cells, by topical, intravenous, or intraperitoneal administration, seated on fibrin matrix as a carrier, seated on contact lenses or biopolymers, seated on amniotic membrane. A fragment of 9 square millimeters of amniotic membrane is covered in just 4 days by 250,000 mesenchymal stem cells. And it is really easy to suture to the ocular surface. To increase the effect, we are introducing under the amniotic membrane a clot of fibrin embedded in platelet factors. We can also use subconjunctival injection, as we will see, and of course we can use, and it will be a very good idea, a combination of both techniques. Which sources do we use? Bone marrow-derived mesenchymal stem cells or adipose tissue mesenchymal stem cells. In an experimental model of limbal insufficiency, we saw that bone marrow-derived mesenchymal stem cells show superior efficacy in reducing corneal development of neovascularization, where adipose tissue mesenchymal stem cells better prevented conjunctival invasion and inflammation. They are not the same. Right now, we are using mainly bone marrow-derived mesenchymal stem cells. Okay, and what about the patients? We did a clinical trial comparing epithelial stem cells with mesenchymal stem cells. And we found that there were no statistically significant differences regarding conjunctival redness, central epithelial opacity, and superficial keratitis. But most important was that the eyes that received mesenchymal stem cells showed a better increase in their phenotype of epithelial cells, which is shown in blue here. The general outcome and survival analysis was more or less the same for both groups. We can see two cases of aniridic patients. This patient had a wonderful results. You can see the epithelial, the corneal epithelial before surgery and after surgery. It is almost a normal epithelium. This case was worse. The result was no good, but the previous state of the patient was very bad. Well, we keep going, and we are launching the regulated use of mesenchymal stem cells by subconjunctival application. There are already several clinical trials of subconjunctival mesenchymal cells in eye disease, even in the prevention of rejection in high-risk corneal grafts. This is very interesting because it will be prevented the use of some dangerous drugs. 2 million of mesenchymal cells can be injected in the 4 quadrants of the bulbar conjunctiva. They have a lot of advantages. It is easy achievable in routine care, minimally invasive. It can be used in severe conditions. A high cell dose can be administered in a small volume. You can administer 2 million of cells in 1 cubic centimeter. No cell culture are needed, no carriers needed, and there is an important time and expense reduction. Well, what are the problems of mesenchymal stem cells? Their toxic effects are not well defined, probably are more theoretical than practical. Anyway, there is a long way to go. My last conclusion is that although the results are not spectacular, these procedures could be the only chance for some patients. I strongly recommend the study of this book by Aliot del Barrio, Corneal Regeneration, Therapy and Surgery, a wonderful book with exciting chapters and a very good chapter dedicated to mesenchymal stem cells. I want to thank the group of the ocular surface at IOBA who has made all this work under the leadership of my great friend, my darling, and my professor's wife, Professor Alcala. Thank you very much.